is now my pleasure to introduce our next speaker, Dr. Cathy Short, who will be presenting an update on Alzheimer's research and clinical trials. Cathy has a special interest in behavioural neurology and the dementias as a group of disorders. She has been working as a neurology staff specialist in the Queen Elizabeth Hospital Memory Disorders Unit since 2003 and has also been actively involved in more than 40 clinical drug trials of Alzheimer's disease and other dementias. Please join me in welcoming Dr. Cathy Short.
Hello, thank you. There's lots of familiar faces in the audience. First of all, thank you very much to Alzheimer's SA for inviting me to speak today. So I'll just start with a brief introduction. There's currently more than 342,800 Australians living with dementia, and the number is likely to approach 1 million by 2050 unless there's a significant breakthrough in treatment. So as of 2015, there's 46.8 million people with dementia worldwide. And this number is expected to double every 20 years to approximately 74.7 million in 2030 and 131.5 million in 2050. The total estimated worldwide cost of dementia as of 2015 is $818 billion US. And this cost has increased by 35% since it was last estimated in 2010. So Alzheimer's Australia have asked me to talk about the latest Alzheimer's disease research today and clinical trials. So there's a lot of research going on both here in Australia and internationally in many different areas. I'm going to touch on some of the following today. So firstly, treatment, looking at drugs, which is a large part of what I do in clinical trials at the memory unit. Non-pharmacological therapies, prevention, epidemiology, looking at risk factors, also diagnosis, looking at genetics and biomarkers. So 24 years after the first descriptions of the therapeutic benefits of Tacrin, which was one of the first cholinesterase inhibitors, we still only have symptomatic therapies for Alzheimer's disease. And only 4 drugs are regularly used for Alzheimer's disease. So donepezil or Aricept, galantamine or Reminal, rivastigmine, which is Exelon, which comes in either a patch or a tablet, and memantine or Abixa. We haven't had a new drug marketed for nearly 20 years. And one of the major obstacles to progress in this field is a lack of understanding as to what exactly causes Alzheimer's disease. So there's been a number of theories proposed to explain the cause, but to date, no one theory can adequately explain all aspects of the disease. And the precise mechanisms for how the disease progresses are also still unclear. So there are 3 major theories at the moment. There's the cholinergic theory, which is what the current treatments are based on, amyloid theory, and also tau. And these are currently regarded as the most likely explanation for Alzheimer's disease, and these are what people are focusing on as a basis for therapeutic development. So I'll just touch briefly on Alzheimer's pathology so you have an understanding of how the drug research is focused. So when we look at brain tissue under a microscope, there are 2 main hallmarks of Alzheimer's disease that we see, and those are the amyloid plaques, which are extracellular, so outside the cell, and inside the neuron there are neurofibrillary tangles, which are made up of tau. So it's amyloid and tau, which are the 2 main pathological hallmarks. And these were first described back in 1907 by Alois Alzheimer. So the amyloid cascade hypothesis has been the main focus of research to date, and the beta amyloid is the main component of the plaques, which is one of the hallmarks that I just mentioned. So scientists now have quite a detailed understanding of how this protein fragment is clipped from its parent compound, which is the amyloid precursor protein, and it's cleaved by two enzymes, so a beta secretase and a gamma secretase. And researchers are developing medications aimed at every point in the amyloid processing pathway. So it's been postulated that after the deposition of these plaques, that a cascade follows. This leads to inflammation and then ultimately formation of these tangles. This causes problems with neurotransmitters, which are the chemicals that send signals between the brain cells, ultimately affecting how the neuron functions, and then ultimately death of the neuron. So one of the strategies that researchers have looked at is immunotherapy, or type of vaccine. So initial studies showed that injecting animals with beta amyloid showed quite a good antibody response and clearing of the plaques from the brains. When they went on to do studies in humans, they had to stop the studies prematurely. This is back in 2002, because about 6% of people developed inflammation of the brain, or meningoencephalitis. However, when they looked later on, they actually found that the treatment had removed the amyloid plaque. So the concept of this active immunisation hasn't been abandoned yet, and there's several companies that are in the early phases of developing new active vaccines. So as an alternative to actively immunising with amyloid, the next studies looked at passively immunising people. So this bypasses the need to respond to an antigen. And passive immunotherapy remains the leading approach today to disease-modifying treatment in Alzheimer's. So these monoclonal antibodies target various domains of the beta amyloid peptide, and they stop aggregation, or they speed up removal of the amyloid. So a number of monoclonal antibodies have been studied in clinical trials, including bapineuzumab, gantenerumab, but some of these were stopped prematurely because they weren't thought to be efficacious. However, further analysis of some of these subgroups have shown some benefits, and this has led to further studies. And there are still a number of monoclonal antibodies that are being actively studied, and some are showing early positive results. So you might have read about some of these in the media: solanezumab, crenezumab, and aducanumab, and we're still waiting the outcomes of these studies. So another approach to reducing the amount of amyloid in the brain is to reduce the production. So inhibiting those enzymes that I talked about before that help make the beta amyloid leads to less of the amyloid being produced. And BACE inhibitors specifically inhibit the beta secretase enzyme involved in the amyloid cascade. And there are a number of studies going on at the moment looking at BACE inhibitors, both at the Queen Elizabeth and the Royal Adelaide. Drugs have also been looked at to inhibit gamma secretase, which is the other main enzyme involved in producing beta amyloid. But there have been problems with quite a lot of side effects with these drugs: skin cancers, rashes, hair discoloration. A drug called semaglutide showed promise in early trials, but didn't show benefit later on in phase 3 trials. And also 2 other gamma secretase inhibitors failed to show benefit. So they haven't lost interest in these drugs. Pharmaceutical companies are currently working on developing more highly selective gamma secretase inhibitors that will cause less side effects and inhibit the amyloid production more effectively. Curcumin is a substance found in the spice turmeric. It has antioxidant, anti-inflammatory and anti-aggregation properties. It also binds beta amyloid and reduces amyloid plaque burden in mice. There is a phase 2 trial ongoing with small numbers of people, and so it'll be interesting to see how this plays out, because it might be quite good because toxicity is relatively low. So I'll turn now to look at tau. Far fewer drug trials have focused on tau, but the interest has grown recently because there hasn't been much luck with the amyloid treatments. And interestingly, most of the preliminary research on mouse and primate models of Alzheimer's disease, they show amyloid plaques that respond to anti-amyloid therapy, but these animals don't replicate the tau pathology that we see in human Alzheimer's disease. And they found that old dogs develop an Alzheimer's-like disorder, that they have both amyloid and the neurofibrillary tangles. And treatment of these animals with anti-amyloid therapies reduces the amyloid plaque load, but it doesn't alter their cognition or change the tau pathology. And we now know that there is a very robust correlation between the amount of tau pathology in the brain and clinical measures of dementia. So methylene blue is the first drug targeting tau, and it's derived from a dye that was used to stain neurofibrillary tangles in neuropathological studies. It primarily inhibits the aggregation of tau, and phase 2 studies have shown cognitive benefits. Also SPECT and PET scans have been encouraging, and phase 3 trial for mild to moderate Alzheimer's disease using this drug has just finished recruiting at both hospitals, Queen Elizabeth and Royal Adelaide, and should all be finished February next year. So it'll be interesting to see the results of this. Several other drugs that inhibit the development of tau have been looked at, and there are some observational studies in geriatric patients taking chronic lithium for bipolar affective disorder, and they were found to have a reduced risk of developing Alzheimer's disease. It seems that lithium inhibits the chemical changes in tau that leads to the formation of the tangles, but studies on lithium have been mixed. Some have shown benefit with very low doses in mild cognitive impairment. Others have shown worsening confusion. So I think we need further studies in this area. And tau immunizations have also been studied in animal models, and they've shown a reduction in the amount of tau and also some clinical benefits in the animal models as well, and some phase 1 trials are starting in this as well. So another way of targeting this disease is looking at certain receptors in the brain. And there's a receptor called the 5-HT6 receptor, which is a serotonin receptor. It's been found that it's a promising drug target for Alzheimer's disease. There's good evidence that it's involved in memory and learning. And antagonising this receptor causes the modulation of a number of other neurotransmitters and pathways in the brain. And phase 2 trials have shown improvement in cognition with the addition of a 5-HT receptor antagonist to people who are already on donepezil or Aricept, who have moderate Alzheimer's disease. And so phase 3 trials are currently underway, and we're recruiting at the Queen Elizabeth Hospital for this trial. So inflammation in Alzheimer's disease is a big area as well. All chronic neurodegenerative disorders and ageing involve a degree of inflammation, oxidative stress, and cellular dysfunction. This leads to impaired function and loss of brain cells, and these brain cells are no longer able to participate in the neuronal networks that we need for cognitive, behavioural and motor function. This leads to a self-perpetuating cycle of cellular injury and predisposition to further insults. Some research suggests that these inflammatory processes are the underlying cause of Alzheimer's disease, and that it leads to the accumulation of amyloid and tau. We've recognised these markers of inflammation in Alzheimer's for a long time. Large epidemiological studies have demonstrated a lower prevalence of Alzheimer's disease in long-term users of non-steroidal anti-inflammatory drugs. There's been a large number of therapeutic trials of NSAIDs in Alzheimer's disease between 1993 and 2004, looking at ibuprofen, indomethacin, naproxen, celecoxib, broficoxib, and also other anti-inflammatory medications such as prednisolone, but all of them were negative. There's a primary prevention study called the Alzheimer's Disease Anti-Inflammatory Prevention Trial, or ADAPT, that looked at naproxen, celecoxib and placebo in cognitively normal elderly with a first-degree relative with dementia. And that trial was prematurely stopped because of increased cardiac and cerebrovascular events, so strokes and heart attacks. Both drugs failed to reduce the incidence of Alzheimer's disease after 2 years of treatment. Interestingly, 4-year follow-up found that those exposed to naproxen were protected from the onset of Alzheimer's disease by 67% compared to placebo. However, because of the tolerability and safety issues, anti-inflammatories are not considered to be a practical treatment option. We'll turn now to vitamins and antioxidants. To date, there's been insufficient evidence that low levels of vitamin B12 in the elderly increases the risk for dementia or that supplements improve performance. And again, studies looking at folate supplementation have also been inconsistent. In 2014, a group of Oxford University researchers assembled all the best clinical trial data involving 22,000 people and concluded that taking B vitamins and folate doesn't slow mental decline as we age, nor is it likely to prevent Alzheimer's disease. Vitamin D primarily has functions in bone health and metabolism, but may also have antioxidant and anti-inflammatory properties. It's not clear whether vitamin D deficiency is causally related to cognition or as a marker for another process. And at this stage, it's not been confirmed that vitamin D supplementation will have a positive effect on cognition. So vitamins E, C and beta-carotene, which is a precursor for vitamin A, are all quite powerful antioxidants. Epidemiological studies show that low intake is associated with increased dementia risk, but the association remains inconsistent. Multiple clinical trials provide evidence that supplements with these compounds did not alter cognitive outcomes in mild cognitive impairment, Alzheimer's disease or healthy elderly, but these results are still debated. There is a concern about the cardiovascular risk of vitamin E. There was a large study done several years ago showing increased risk of coronary events, and it's likely to prevent any further studies in vitamin E in Alzheimer's. Ginkgo biloba has been studied in trials, and there's reasonably firm evidence now that it does not alter the risk of dementia or improve cognitive performance in healthy elderly. And there's also the potential side effects of bleeding tendency and interactions with other drugs. Omega-3 fatty acids found in fish oil and nuts are thought to be neuroprotective. Studies have failed to show any improvement in cognition in Alzheimer's patients. In the elderly without Alzheimer's disease, there's been inconclusive evidence that they may slow cognitive decline. We need further large-scale studies in this area. There's been a lot of the media about the Mediterranean diet lately. It's a diet that's rich in fruits and vegetables, olive oil, legumes, whole grains and fish. Studies have shown that people that closely follow a Mediterranean diet are less likely to have Alzheimer's disease than those who don't. Research suggests that a Mediterranean diet may slow cognitive decline in older adults, may reduce the risk of mild cognitive impairment progressing to Alzheimer's disease. It may slow the progression of Alzheimer's disease and prevent disease-related deaths. There's also a recent study that looked at 3 different diets. Mediterranean diet, the DASH diet, which is a diet designed for hypertensive patients, which is basically low salt and sugar, and the MIND diet, which is a combination of the above 2 diets, and it emphasises natural plant-based foods, limited saturated fats, encourages the consumption of berries, green leafy vegetables, which are known to benefit brain health. And people that strictly followed any of these 3 diets had a lower risk of Alzheimer's disease. Even a modest adoption of the MIND diet approach, such as eating 2 vegetable servings a week, 2 berry servings a week, 1 fish meal a week, appeared to lower the risk of Alzheimer's. Researchers speculate that making healthy food choices may improve cholesterol and blood sugar levels and overall vessel health, which may in turn reduce the risk of mild cognitive impairment and Alzheimer's disease. Another theory is that the Mediterranean diet may help prevent brain tissue loss, but we need more studies again to know to what degree this diet prevents Alzheimer's or slows cognitive decline. Brain training, it's quite a broad term and it can include a range of structured mentally stimulating activities, including crosswords, learning a new language, reading a book, undertaking further education, or dedicated computerised brain training activities that focus on memory, attention and cognitive function. Recent studies have found that computerised brain training is only modestly effective at improving cognitive performance in healthy older adults. Further studies are about to start to see whether intensive computerised training can stop the progress of cognitive decline and the onset of dementia. Physical activity. Research into the potential for physical exercise to reduce the risk of dementia is continuing. We don't have any randomised controlled trials available yet, but several studies have found that physical activity in early, mid and later life is associated with lower risk of cognitive decline and dementia. Other studies have found that people who exercise experience a slower loss of brain tissue as they age, and also people who exercise regularly are less likely to have cerebral and cardiovascular disease, which in itself is associated with an increased risk of Alzheimer's. It's also beneficial in patients that have dementia, so it can help prevent muscle weakness, mobility problems and other health complications associated with inactivity. Also helps reduce the symptoms of stress, anxiety and depression. 3 types of exercise should be included in the program, including aerobic exercise, weight training and flexibility and balance training. And if an exercise program is incorporated in the early stages of dementia, it's more likely to be maintained as the disease progresses. Insulin resistance and the way the brain processes insulin may be linked to Alzheimer's disease. And researchers are exploring the role of insulin in the brain and the closely related questions of how the brain cells use sugar and produce energy. Researchers have been studying a diabetic medication such as pioglitazone, which also has potent anti-inflammatory effects. Preliminary studies with pioglitazone have had mixed results, but there is a worldwide phase 3 study underway. There's one site in Melbourne. And this study is looking at cognitively normal patients who are considered at risk of developing Alzheimer's and giving them either pioglitazone or placebo, and also giving placebo to those considered at low risk, and the results are pending. So vascular disease in Alzheimer's. We now know that vascular risk factors such as hypertension, heart disease, smoking, high cholesterol, obesity, stroke, diabetes are also risk factors for Alzheimer's disease. It's quite a complex relationship between vascular disease and Alzheimer's, and we still don't completely understand it. But the current thinking is that pre-existing vascular disease in the brain is likely to lower the threshold for clinical expression of Alzheimer's pathology. Some observational studies have shown that the rate of cognitive decline in Alzheimer's is reduced with better management of these vascular risk factors, but results have been inconsistent. We need larger randomised controlled trials over longer periods of time to determine the effectiveness of the treatment of vascular risk factors in Alzheimer's disease. The Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability, which is a mouthful, it's also called the FINGER study, is one such study that's showing promising preliminary results at 2 years, and it's looking at the benefits of a combination of diet, exercise, cognitive training and vascular risk factor monitoring in an at-risk population. Researchers obviously also looking into the genetics of Alzheimer's disease, because we can learn a lot from families that have genetic mutations. There are 3 known mutations that cause familial Alzheimer's disease, and this accounts for a very small percentage of Alzheimer's disease overall. And there are several new studies looking at anti-amyloid drugs in asymptomatic patients who either have one of these known rare genetic mutations or are at very high risk of developing Alzheimer's based on their family history. And it's hoped that these studies will give us some more insight into whether treatment at the asymptomatic stage will prevent later development of Alzheimer's disease. The Alzheimer's Prevention Initiative, or API, is an international consortium established to conduct research into an extended family in Colombia, in South America. There's 5,000 members of this family, and they all carry the presenilin 1 mutation that affects amyloid processing. The API are performing a study on asymptomatic individuals that carry this mutation, and they're using the monoclonal antibody, crenezumab, and comparing it with placebo. It's a 5-year study and still recruiting. The DIAN network is dominantly inherited Alzheimer network. It's an international initiative funded by the NIA in the United States. And this network tracks individuals from families in whom an AD mutation has been found. One of their goals is to detect physical or mental changes that distinguish those that inherit a mutation from those who don't. The DIAN-2 study is looking at asymptomatic patients with a known mutation or at very high risk of developing Alzheimer's and treating them with one of 2 monoclonal antibodies against Alzheimer's, against amyloid, either solanezumab or gantenerumab versus placebo. There's one site in Australia who are involved in this study. It's at the Austin Hospital in Melbourne and due to finish at the end of 2019. Turn now to biomarkers. So making a diagnosis of Alzheimer's is still essentially a clinical diagnosis, and it's generally not a difficult diagnosis to make when the disease is clinically obvious, but can be very challenging when the disease presentation is early or it's atypical. So having a diagnostic biomarker would avoid any uncertainty and allow us to have a definitive diagnosis. At the moment, we can only have a definitive diagnosis with evidence of brain tissue and seeing the tau and the amyloid under the microscope. So in addition to looking at a range of experimental drugs, a range of clinical trials are also in progress looking at various imaging techniques. So looking at PET scans with amyloid and tau traces, also testing a range of potential biomarkers in cerebrospinal fluid and blood. And we hope that these techniques will one day provide methods to definitively diagnose Alzheimer's in its earliest and most treatable stages. If we could diagnose before symptoms appear and start treatment in the asymptomatic phase before significant degeneration of the brain had occurred, it would be ideal. We know that the pathological changes of Alzheimer's can start up to 20 years before symptoms present, and we can see this with evidence of amyloid deposition on PET scans. And it's perhaps a reason why many trials that we've done in the past that have been done on people with mild to moderate Alzheimer's disease haven't been effective because we've been treating too late in the disease process. And biomarkers will also eventually be able to offer better methods to monitor response to treatment as well. So there are often no simple solutions to complex problems, and Alzheimer's is probably a good case in point. I think the clinical trial results to date have been disappointing for several reasons. Our understanding of the pathophysiology, the range of causes and how it progresses from preclinical to advanced disease is still quite limited. Perhaps there's been too great a focus on amyloid-directed therapy. We need to look at non-amyloid targets such as tau, antioxidants, neuroprotective drugs and others, and also that we may have been giving treatment too late in the disease process. So in the future, Alzheimer's may be treated like other chronic diseases with a mixture of disease-modifying and symptomatic therapies used in combination and in sequence. The scenario might be something like starting a cholinesterase inhibitor, such as Aricept or donepezil. We might then add in a disease-modifying drug, such as a monoclonal antibody. We might then change to another disease-modifying drug if the disease progresses. And then we might consider changing or adding another agent, such as a BACE inhibitor or a 5-HT receptor antagonist. The limitations obviously will be side effects and affordability. So I think although there have been many obstacles and setbacks along the way to developing treatment, I think the future still looks promising. We're hopeful that an effective treatment will become available in the near future, and there's trials of several promising agents underway here and internationally. I'll just briefly mention clinical trials in South Australia. So the Royal Adelaide Hospital and the Queen Elizabeth currently both have Alzheimer's disease clinical trial centres. Soon we are going to be combining to one more centralised Alzheimer's trials centre based at the Queen Elizabeth. And this will be co-located with a large multidisciplinary memory service. And this is going to be known as the Central Adelaide Local Health Network Memory Service. There's going to be a multi-D approach to diagnosing and managing dementia, and the hope is that we're going to have ongoing support for patients and their carers with a case manager. So currently at the Royal Adelaide, they've got a number of trials. They're doing a study with a BACE inhibitor, looking at prodromal Alzheimer's disease, but also mild to moderate Alzheimer's disease. This is running over 2 years. You can be on any Alzheimer's treatment to be eligible for this. They're also doing a Marguerite Road study, which is looking at the monoclonal antibody gantenerumab. Runs over 2 years, and that's in mild Alzheimer's disease, mini-mental of 20 to 26. They're doing another BACE inhibitor study in prodromal and mild Alzheimer's disease called the Amaranth study. And they're also about to start a study with AZ Therapies, which is looking at inhaled anti-inflammatory medication called Intal, which has been used a lot in the past for asthma, and also ibuprofen. At the Queen Elizabeth, we're also doing the Merck BACE inhibitor study. We're also doing a study looking at a 5-HT receptor antagonist over 6 months, which we're actively recruiting for. Also the Marguerite Road study looking at gantenerumab in mild Alzheimer's, and we're looking at starting another monoclonal antibody study late this year, early next year, looking at crenezumab. So thank you very much for having me today. If there's any questions, please sing out. I'll try and answer them. But if you're interested in being involved in any clinical trials, there's the numbers there, and I've also put some flyers on the table at the back if you're interested, or if you want to come and see us at the Memory Trials Centre, by all means, ring up. I'd love to see you.